rehab specialist, also known as we had talked about this, a physiatrist in the Department of Physical Medicine and Rehabilitation. She attended and graduated from Eastern Virginia Medical School in 2012 and has over 7 years of clinical experience. She specializes in cancer rehabilitation, cancer survivorship, lymphedema management, and other relevant conditions relevant to the cancer survivorship experience. Today, she will be speaking to us on movement matters, the importance of exercise before, during, and after treatment. And I can tell you personally that all the patients that we've referred have always come back to us so happy and feeling like they really have a plan of action of where to go. And several of our patients, until they saw you, had not made the decision to go back to work. And we've had several that you've really helped them to get to that point where physically and then emotionally, obviously, they're able to go back to work. So thank you so much for being here.
Hi, everyone. Good afternoon. I was very much looking forward to being here, so thanks for having me. Today, we'll be talking about the importance of exercise before, during, and after cancer treatment. The objectives will be to review current exercise guidelines, dive into cancer rehab, prehabilitation, common cancer complications, and the role that exercise plays with them. And lastly, we'll talk about the role of exercise in weight management. So the field that I'm a part of, it's called Physical Medicine and Rehabilitation. It's also known as Rehab Medicine. It's a team-based approach to improve quality of life and functional independence of patients. So essentially, we try to maximize what a patient can do, and we try to help them adapt to the things that he or she may no longer be able to do. Rehab occurs mostly in two different settings. On the inpatient rehab, these patients are usually admitted to acute care inpatient because of an injury or illness. Whatever injury or illness renders them with new impairments, things that they used to be able to do without any problem, they can no longer do. If they are able to tolerate 3 hours of therapy a day, they can be admitted to an inpatient rehab hospital. In this setting, they see a physician every day for medical management. They get social work services. They're seen by a neuropsychologist to help them with adjusting to their new problems. And they also undergo 3 hours a day, which is a lot of exercise, between physical, occupational, and speech therapies. Common diagnoses that we see on our inpatient rehab would be something like a craniotomy for brain tumor removal, spinal cord injuries because of bony, spinal metastases, but also deconditioning from after a bone marrow transplant. On the outpatient side, we frequently see patients who aren't yet ready for surgery or are hoping to avoid surgery. We commonly provide a variety of types of injections for muscular, joint, or spinal problems. We prescribe durable medical equipment, so things like wheelchairs, walkers, canes, bracing. We also evaluate and prescribe physical or occupational therapy prescriptions with specific treatment goals. This picture here is the new Christine E. Lynn Rehabilitation Hospital that they're building.
Where's that going to be?
It's right next to, on the other side of Mailman. You might have noticed all the construction.
Oh, yeah, it's going up now.
But we have inpatient services now, so you can send right away. So cancer rehabilitation uses the same interdisciplinary and multimodal approach, but for cancer patients. We help oversee the safety, selection, and implementation of impairment and disease-specific treatments. In addition to the medications and the bracing and the different kinds of injections, we also perform electrodiagnostic studies. So this can be helpful to detect a treatable neuropathy from something that there's no cure for, like chemotherapy-induced neuropathy. We also provide exercise counseling and precautions. The goal is to boost a patient's function so that they can tolerate their cancer treatments and assist them in returning to their prior level of function. So common diagnoses I see on the outpatient cancer rehab clinic might be something like lymphedema after lymphadenectomy, It could be neck stiffness or pain because of radiation fibrosis. It could be decreased hand dexterity, problems with their balance because of chemotherapy-related neuropathy. But also sometimes I see leg weakness or arm weakness because of intraoperative nerve trauma. Some cancer statistics. Unfortunately, the incidence of cancer is still rising. However, thankfully, we have advances in technology, different kinds of medications, immunotherapy, and earlier detection allow for the death rate per year to be decreasing. Survivorship is also growing at a fast rate. This year it's projected to be 16.9 million, and by 2040 it's projected to hit 26.1 million people. If you do the math, the prevalence of survivorship is growing disproportionately to the incidence of new cancer cases. Cancer survivors, who might be someone here in the audience or likely a friend or family member of yours, they face unique physical, psychosocial, and financial challenges. There's a lasting burden of the treatment and the financial toxicity. We have to shift the way we see cancer to one as more of a chronic, debilitating disease that can have profound effects on quality of life. So physical activity is not the same as exercise. Physical activity is just any movement. Exercise is planned, structured, repetitive body movements done with an intention to improve or maintain your physical fitness. The U.S. Department of Health and Human Services first put out a guide for physical activity and exercise in 2008, likely related to the growing obesity epidemic, and in children, they put out a guide for youth in 2013. The most recent guidelines were published last year and were all-inclusive for people of all ages. Move more, sit less. Why? As our sitting time increases, here in the red, so does the risk of all-cause mortality. As you incorporate more moderate to vigorous physical activity or exercise, here in the green, the risk of all-cause mortality reduces. You can start doing this right away. On the left, this is us on our smartphones, at the computer, in UChart. Get up, take frequent breaks, take the stairs instead of the elevator, get lunch on the other side of campus. There's many different ways to get this in, and every little bit adds up. Different types of exercise include aerobic, so this is rhythmic movements of your large muscle groups for a sustained period of time. So things like dancing, walking, running, jogging, biking, those all count. Strengthening exercises increase skeletal muscle strength, power, endurance, and mass. This can be done by lifting weights, using resistance bands, or even body weight exercises, which tend to be more functional in nature. So that's something like jumping jacks, planks, mountain climbers, lunges. Flexibility exercises work to improve the range of motion of a joint. This is really important to help prevent injuries. Balance exercises improve your equilibrium, and they also facilitate coordination and reaction time to help prevent falls. Bone strengthening exercises are also referred to as weight-bearing activity, and they promote bone growth via impact and tension forces on the bones. Many aerobic and strengthening exercises qualify as bone strengthening exercises. When it comes to planning exercise, it's important to establish a plan. Select a type. Decide how often you will do it. Decide the frequency. Decide the timing. How many minutes will you do at a time? How many sets or how many repetitions? And then also the intensity. The intensity refers to how much force you're putting into it compared to what you're capable of. So in absolute terms, moderate intensity is defined as 3 to 5.9 METs. On a more practical scale, so a relative scale would be your own personal scale. So 0 to 10, 0 is laying on the couch. 10 is the most effort you could ever do, and you'll be really out of breath. So for moderate intensity, you want to be at a 5 or 6 on your own scale. Vigorous intensity, defined absolutely as 6 or more METs. On a relative scale, around 7 or 8 out of 10. Another way to think about it is something called the talk test. So if you're doing moderate intensity exercise, you should be able to talk but not sing. If you get to the point where you can barely say a few words at a time, that's closer to vigorous intensity. So the guidelines for adults with chronic health conditions and disabilities is actually the same as healthy adults with a few modifications. The recommendation is for 150 minutes to 300 minutes a week of moderate intensity exercise. So this could look like 30 minutes of walking 5 days a week. Or 75 to 150 minutes of vigorous intensity exercise. So this could be faster running for 30 minutes 3 times a week. Ideally, the aerobic activity should be spread out throughout the week. At least 2 days a week, there should be muscle strengthening exercises of moderate or greater intensity in all major muscle groups. On the days that strengthening exercises are done, you should also do some mobility and flexibility exercises to restore range of motion, reduce pain, and reduce the risk of injuries. If someone's not able to meet these key guidelines, it's okay, but they should stay active within their abilities and at all costs avoid inactivity. People with chronic health conditions should consult with and be under the care of a healthcare professional about the types, amounts, and amount of activity appropriate for their abilities and chronic condition. So we already established that exercise reduces your risk of all-cause mortality, but why else? Are there any other benefits? There are so many. So anxiety, depression, sleep quality, bone health, preventing or treating osteoporosis, getting to a healthy weight, maintaining a healthy weight, reducing your risk of falls, reducing your risk of dementia, reducing your risk of cardiovascular disease, and also reducing your risk of cancer, different GI cancers, renal cancer, lung cancer, breast cancer. So exercise can be introduced at any point along the cancer care continuum. On the acute hospital setting, like perioperative or around the time of chemotherapy, it could be introduced. If the patient's not able to go home, they might go to an acute inpatient rehab hospital and get specific therapeutic exercises there. They might participate in a day program or an outpatient therapy programs or do independent home exercise programs. Exercise can also be introduced prior to surgery, prior to chemotherapy, as part of a prehabilitation program. So cancer prehabilitation is using screenings and interventions before upcoming major stressors like chemotherapy, surgery, radiation, which we know will cause a reduction in their function. It should consist of dual psychiatric and physical components and provide multimodal interventions. It's an excellent way to utilize the time between when the patient's diagnosed and when they'll actually initiate treatments. It allows for more seamless integration to the cancer support services throughout the care continuum. The protocols for prehabilitation should and will vary by disease group. So prehabilitation is introduced here prior to surgery with the idea of increasing a patient's functional capacity. After surgery, we know that folks who get prehabilitation and folks who don't will both suffer a reduction in their function. The idea is that patients who receive this preoperative prehabilitation will have a faster return to their functional baseline. So this study looked at the effect of trimodal prehabilitation in colorectal cancer patients. The intervention included preoperative nutritional counseling, protein supplementation, anxiety reduction, and a moderate exercise program. People received this for about 33 days. They found both groups had similar lengths of stay and post-operative complications. However, At 4 and 8 weeks, the intervention group had better postoperative walking capacity. At 8 weeks, the treatment group, 81% reported full recovery. In the non-treatment group, 40% reported recovery at 2 months. This systematic review looked at 17 different articles, including 800 patients who receive a 1 to 4 week exercise intervention. They found that this helped significantly reduce postoperative complications and lengths of hospital stay in lung cancer patients. Cancer-related fatigue. So this is a persistent, unrelenting, subjective sense of exhaustion. It can manifest physically, emotionally, cognitively, or some combination thereof. It's usually related to cancer or the cancer treatments. It's not proportional to what the patient is currently doing, and it really interferes with their usual functioning. Different possible biological mechanisms include pro-inflammatory cytokines from the tumor itself, dysfunction of the hypothalamic pituitary adrenal axis system. Many of the patients get hormone deprivation therapies. Others get really large cumulative doses of corticosteroids. Sleep rhythm dysfunction, skeletal muscle wasting may contribute. Other associated risk factors include genetic single nucleotide polymorphisms, psychological factors like depression or anxiety, and physical factors like inactivity. This study looked at the effect of exercise in 163 prostate cancer patients who were undergoing androgen deprivation therapy. They had 3 different intervention arms. One arm consisted of impact and resistance exercises. They got these in a supervised setting twice a week for 12 months. The second group received aerobic and resistance exercises. For the first 6 months, they were supervised, and the last 6 months, they performed these at home. In addition, they also did 150 minutes a week of aerobic activity. The third group, the usual care/delayed exercise, just got a booklet for the first 6 months of, what is exercise. For the last 6 months, they changed gears and had them do supervised exercise for at least twice a week. The outcome measures they used were the EORTC Quality of Life Questionnaire to evaluate fatigue, the short form 36 to evaluate vitality. So vitality refers to someone's ability to live life vigorously with energy. What they found was that fatigue was reduced in the impact and resistance exercise group at 6 and 12 months. Fatigue was reduced in the other 2 groups by 12 months. They found that vitality was increased significantly at 1 year in all 3 arms. Interestingly, those with higher levels of fatigue and lower levels of vitality responded the best to this intervention. So lymphedema. So lymphedema is the clinical manifestation of lymphatic system insufficiency and deranged lymphatic transport. Why is this happening? There's low output failure because of mechanical insufficiency in our patients because of surgical resection, because of radiation, or because of the tumor itself. It leads to a buildup of water, proteins, and other cellular tissues that can lead to fibrosis or hardening of the tissue in the skin. That affected extremity is technically immunocompromised because the lymphatic system helps with transport of fluid, but also helps fight infections. So that extremity is at an increased risk of cellulitis. The incidence when breast cancer patients who get an axillary lymph node dissection is about 20 to 30%. It's a lot lower in patients who just get a sentinel lymph node biopsy. However, if they also get radiation and chemotherapy, that increases their risk. Both sarcoma and lower extremity melanoma are about 30%, gynecologic about 20%, and head and neck about 3%. On the left is an example of a patient with lower extremity lymphedema. On the right, upper extremity lymphedema. And this is a gentleman with pretty severe lymphedema of his neck prior to treatment, and on the right, after treatment. When I see these patients in clinic, the first step is to confirm the diagnosis, make sure this is actually what they have. The second step is counseling, making sure they understand their condition, that there is no cure for lymphedema, and that for a successful treatment and management program, they have to take an active role in self-management. And then the third step would be getting them in with a certified lymphedema therapist. So this review looked at 11 randomized controlled trials of 458 women with breast cancer in aftercare. The interventions of exercise range from water-based to resistance to aerobic to yoga. 4 of the studies found significant reduction in the actual arm volume itself with the exercise group. 7 studies reported significant subjective reports, so the women were saying they felt a lot better. Importantly, no study showed adverse effects of exercise on lymphedema. I think there's a lot of fear that this condition might occur. People might develop fear avoidance of movement, which leads to a negative spiral of not moving, gaining weight, and gaining weight will for sure worsen lymphedema. The American College of Sports Medicine put out a roundtable of guidelines for exercise for cancer survivors. They said no exercise restrictions are recommended regarding breast cancer or lymphedema. Impaired attention, concentration, processing speed, executive function, or memory, these problems are part of cognitive dysfunction. About 30% of patients report some of these symptoms before they've ever even received treatments. About 75% report these type of symptoms as they continue to get treatment. It can be related to the tumor or the treatments. It can affect quality of life, make it difficult for someone to return back to work, and impede your ability to fulfill your social roles with your friends and family and maintain relationships. It could lead to poor compliance with treatments and follow-up appointments. Risk factors include one's cognitive reserve, their age, genetic factors, and any comorbid mental health conditions. So this study looked at exercise in 299 breast cancer survivors. For baseline measurements, they all wore something called an ActiWatch. It's an accelerometer to capture their average daily minutes they spent in moderate to vigorous physical activity. They also performed brain baseline testing to evaluate their working memory and their overall executive function. What they found was that patients who had higher daily amounts of moderate to vigorous physical activity had lower fatigue symptoms. They also found that lower fatigue symptoms were associated with faster scores and times on executive function tasks and accuracy on memory tasks. So we all know cancer diagnosis is a life-changing event. There's the threat of death, uncertainty, loss of control, stressful treatments, and then ongoing reminders of cancer everywhere. There's a well-documented prevalence of clinically significant post-traumatic stress symptoms in patients who have completed treatment. Possible biological contributors can be pro-inflammatory cytokines from the tumor, but also side effects from the chemotherapy drugs. So this study looked at patients 60 years or older, 252 of them, who were actively getting chemotherapy. The intervention group received Exercise for Cancer Patients Program, or EXCAP, or usual care. The outcome measures used were the State Trait Anxiety Inventory, Profile of Mood States, and the FACT-G, Emotional and Social Wellbeing. The EXCAP program specifically it's a home-based program. There's 2 components. One is aerobic, and they're all individually tailored. It's a progressive, moderate intensity program. The patients are instructed to increase their steps by 5 to 20% per week. For the resistance portion, they were given therapeutic resistance bands of different strengths. They were instructed on 10 required exercises, and they were given an individually tailored repetition scheme to complete. At the baseline, for most of the outcome measures, there were no significant differences in the intervention and the control group. At the end of 6 weeks, there were statistically significant changes in the anxiety, profile of mood, and social and emotional well-being groups, outcomes. They found there was a 71% adherence to the exercise program, and importantly, there are no adverse events reported to these patients doing exercise while getting chemotherapy. So, chemotherapy-related neuropathy. It affects about 30 to 50% of patients who get neurotoxic chemotherapy. It's usually dose-limited. Unfortunately, there's no preventative measure that we know of. It's typically in a stocking glove distribution. Usually affects sensory fibers, so that will give you symptoms like numbness, tingling, pain. But it can also affect motor fibers, so that would be that could lead to weakness or muscle atrophy. It can also affect autonomic fibers, so you might have symptoms like orthostasis, so getting lightheaded or dizzy when standing up. The study wanted to determine the prevalence of neuropathy, chemotherapy-related neuropathy symptoms reported after chemotherapy had concluded. They also wanted to compare objective and patient-reported measures of physical function and disability. They also wanted to examine the relationship between the symptom severity and these outcomes. The study included 512 female cancer survivors, average age of 62, and on average about 6 years after treatment. What they found, this is the objective measures. So women who reported high levels of chemotherapy-related symptoms had overall worse gait patterns, worse walking patterns. They had a lower walking speed. They had a shorter step length. They spent more time in stance phase and double stance phase of the gait cycle. They also tended to spend more time sitting in a chair. The women with higher symptoms also perform more poorly on physical performance batteries. This physical performance battery is a validated tool that is correlated with disability, hospitalizations, and admission to nursing homes. The subjective measures found that women with higher reported symptoms reported worse overall lower extremity function, as well as more disability. And they also found that these women with more symptoms also reported more falling. Overall, the investigators found 47% of patients after chemotherapy still reported chemotherapy-related neuropathy symptoms. The women with more symptoms had significantly worse self-report and objectively measured outcomes. The women with symptoms had almost 2 times the risk of falls compared to women without neuropathy symptoms. They concluded that increasing symptom severity is linearly associated with worsening function, increasing disability, and higher fall risk. This study used the EXCAP, that exercise program home intervention, to look at the effect of it on patients who were receiving chemotherapy. So it was a multi-center randomized controlled trial. These patients were getting taxane, platinum, or vinca alkaloid-based chemotherapy. In addition to determining the effect on their overall function, they wanted to find any factors that might predict for chemotherapy-related neuropathy. What the study found was that in both control and exercise groups, both of them reported increasing severity of numbness and tingling, as well as hot and cold sensation in the hands and feet as chemotherapy continued, which makes sense. But what they found was that the amount of increase in the hot and cold sensation in the hands and feet was statistically significantly less in the exercise group than the control group. Although not statistically significant, it was still overall less increased in the exercise group for numbness and tingling severity compared to the control group. They found factors that predict increase in neuropathy symptoms include female gender and baseline neuropathy, so like things like diabetic neuropathy. 72% of exercises said that this study changed their opinions of regular exercise during chemotherapy. After the intervention, they also found that the exercise group average daily walked a quarter mile more per day. And importantly, no adverse events were found related to the exercise. So nutrition. So a good nutrition program is something that, just like exercise, can and should be implemented, preferably before treatments. It can also be implemented during or after cancer treatments. Adequate nutrition and protein supplementation is important to prevent excessive weight loss and also to promote healing. Nutrition is also a really important part of obtaining and maintaining a healthy weight. So obesity has been long related to an increased risk of cancer, of many different types of cancer, different GI cancers, multiple myeloma, renal cancer, ovarian, uterine, and breast. So no matter how much you exercise, you can't out-exercise a bad diet and poor nutrition. However, for me, living a life without ice cream is a life without joy. So it's really important to find moderation, balance, and portion control. So exercise. So I found that if I tell a patient, go exercise, it's not likely to happen. It's not a very specific or very clear instructions. So if I had a patient with an arm infection that I wanted to treat, if I wrote antibiotic on the prescription, they probably wouldn't get better. It's not specific and it's not tailored to whatever they're suffering from. So something that would work better would be a specific medication, a dosage amount, how often to take it, and how long to take it for. So when prescribing exercise, we like to use the fit exercise prescription. So frequency, so how often it's being done, the intensity, how hard you're doing it, the timing, how long you do it for, how many repetitions you will do at a time, and then the type, what kind of exercise. So a better example of saying, instead of saying go exercise, might be you're at the point where you can begin walking, the type, 4 days per week, the frequency at moderate intensity, and then the 30 minutes at a time. So key guidelines for safe exercise to reduce the risk of injuries and other adverse events. So start low and go slow. Choose types that are appropriate for their current fitness level. Use protective gear. Pick safe and smart environments. Patients with cancer should receive guidance from an exercise specialist. Factors that should be considered in initiating or returning to an exercise program include their other medical comorbidities, if they have any musculoskeletal and neurological or cognitive impairments, if they have any bone problems such as osteoporosis or bony metastases, and also their motivation level, as well as their prior exercise history. You know, what do they know how to do already? What is their past experience? All these things should factor in and determine, is this someone who will do well with guided home instructions? Or can I print out some basic exercises for them? Or should I send them to our exercise physiologist, Chris? Or do they have worse, lower level of function and need to see a physical therapist? So what's your move? So explore, be adventurous, find something that you love to do and will keep doing. So set an intention, decide you will do something. Set specific, achievable goals, and be consistent. Establish a routine. If you deviate from it, that's okay. Come back to it. It's the cumulative effect in your lifetime is what matters. So in summary, cancer prehabilitation prior to interventions can boost functional capacity and enhance treatment outcomes. Studies involving cancer patients are consistently showing improvements in fatigue, vitality, cognitive dysfunction, mood disorders, sense of well-being. Exercise does not cause or worsen lymphedema. It can improve lymphedema objectively and as well as lymphedema symptoms. Exercise may improve symptom severity with chemotherapy-related peripheral neuropathy. Moderate levels of exercise are well tolerated and beneficial in patients actively receiving chemotherapy. For guidelines on return to activity or to initiate an exercise routine, the patient can and should be referred to a specialist. Thank you. Any questions?
Do you try to involve family and friends in their exercise programs?
Absolutely. It's a great way for them to engage their support system, to kind of get out of their mind and do something physical. Also, I encourage use of technology as well. So step counters, different applications, as well as smartly selecting certain content online.
First of all, thank you for the presentation. The slide you had about different types of exercise, right? There was impact training, strengthening, mobility. So let's say, for instance, a patient who has breast cancer metastasis to the bone, which is particularly osteolytic, since it's a very fragile patient, what type of exercise would be recommended for that patient?
Yeah, that's a great question. So it really depends on where the bony lesion is. Is it a weight-bearing bone that it's affected? And then also how large the lesion is. What circumference of the whole bone that it makes up would it help impact what the patient can do. In general, if it's a weight-bearing bone, then I would recommend low-impact activities. So something more like resistance bands. Definitely some flexibility exercises. If they really want to do something aerobic, maybe something like the glider or the elliptical instead of the treadmill, which is higher impact, or the stationary bicycle. If we want to go really low impact, then we can get in the pool and do water-based exercise. Yes?
Are there any universal measures of exercise effectiveness that you use? Just overall across the board gives you an idea of how effective the interventions are?
So there's a lot of heterogeneity with the research and exercise and the different kinds of outcome measures. There are some collective batteries that might include things like common measures would be something like a 6-minute walk test, a time get up and go test. So like how long it takes the patient to get up out of a chair and walk like 10 meters. So those are some of the common ones.
And do you use them in?
No, I don't use those. Those would be difficult to use in a clinical setting. Some things that, more basic things that I can do on my own and in a limited context of outpatient visit might be I time them with single leg standing balance would be one example, and that's something we can track and see. I can also have them, walk. If it's someone who's really low functioning, I could have them walk 10 feet and measure that and record it for next time. Another thing is that I like to do as a quick check to see like where they're at is to have them stand up without the use of their hands. It helps to give me an idea of their their proximal hip strength. All right. Thank you.